Cast is now starting. All attendees are in listen-only mode.
Hey, Rich, how you doing?
Good evening, Dr. Yatros. I'm doing very well here in Texas. How's it going in Florida there?
Very good. I'm really excited tonight about this webinar. If we've done this one before, it's been a long time ago, and I think this is, we've got a really big turnout of, I think, over 400 people registered, which is because it's a subject a lot of people are intimidated. When we teach dentists how to do this, I think they get that sleep test in their hand and they just want to go do something else because it's unfamiliar. And by the time the night's over, we hope that everyone on here can be very confident in at least picking up the sleep test and knowing where to go from there. So without further ado, we'll get started. This is what we do. We teach dentists how to treat sleep apnea. We call it our 4 pillars: screening, testing, treating, and billing. So today we're going to talk mostly about testing, and we're going to talk about literally getting down and looking at these tests. We have sample tests to look at and kind of dissect, and then we'll talk about testing at a high level for those of you who maybe want a little more information on that. So we have an hour, and I'm excited about this. This slide here, Rich, we've been using a long time. I think I got this from our good friends at Braybond over the years. We've done a lot of courses with them over the years, and I just think this explains what we're trying to measure, at least.
I think, Guy, we could talk about this slide for an hour if you wanted to. You know, there's a lot of information here, and I'd like to preface this by saying, like you said, Guy, you know, you can figure this out. You don't be intimidated by it. You know, every day I have a staff member guy come up and they go, Dr. Drake, I just can't find the AHI. And, you know, it takes me 5 minutes to find it because it's always different. These reports are always different. You know, sometimes you just got to get a cup of coffee and sit down and, you know, take a couple of minutes to do it. But we're going to hit the high spots. And by the end of tonight, you're going to feel a whole lot better, I promise you, about not only how to find this information and what to look for, how to find it, but also what some of it means. So we're trying to put meaning behind it, too.
And what to do with it. So just real quick on this slide, when we're measuring breathing, whether it's with a nasal cannula, a thermistor, we'll talk about that in a few minutes. We're just breathing the breath in and the breath out. And that's what we want to see is breath in, breath out. And then here we can see reduction. And we have, that's the last line there. So there's not a fine line. You don't jump from one to the other as we're measuring the breathing. When we talk about apnea, we're talking about a cessation of breath for 10 seconds or longer to be defined. So we're measuring that breathing, and we'll talk about the various instruments we measure that with and what those say on the test in a moment. But just to make sure we're all on the same page, and apnea is when you quit breathing. You're breathing, and then there's a cessation of breath for 10 seconds is how we define an apnea. And we may have periods of breathing with apneas in between is very common to see as we read sleep tests. So that's the first squiggly line that you're going to want to look for on these tests. And is the breathing, whether that's measured with pressure, or some of them are measured with things called thermistors, which measure the actual temperature of the air going in and out. Some do both. And I think some actually measure more flow as well. But I think the most common are pressure and thermistors. And this is what, hypopnea. I don't know if I always say that right. Some people say hypopnea. I guess it's whether you're from the South or not. What do you call it, Rich?
I like hypopnea. You know, that's what we call it here in South Texas. So, you know, it's similar to an apnea, but at least we still have some air movement. You know, it's kind of like, I like the analogy, Guy. Instead of breathing through 10 straws, I'm just breathing through 2 straws.
Right.
You know, I'm still getting air, but I'm getting not enough air, and I'm getting enough reduction in that airflow that my O2 starts to drop again. You know, most people are using 3% when we look at how much the O2 has to drop, and then for how long. Some tests use 2%, some use 3%, some use 4%, and that's another thing that you want to make a note of tonight to make sure you're comparing apples to apples. If you have a baseline study where they use 4% and then you do a follow-up home sleep test with your dental device and they use 2%, of course they're not going to be the same. So that's just another thing, but I like hypopnea.
Yeah, hypopnea, 10 seconds of reduced breathing with a desaturation associated. Hey, Rich, you don't have to have a headset nearby, do you? Because I've got a text that we're getting a little bit of echo here. If you don't, we'll just go on without it. Just try not to maybe talk a little more into the mic there so that we don't get as much echo. Do you have one readily available?
If I had one, it would be on my head.
Okay, okay. Well, we'll try to, I think maybe if you sit closer and don't talk as loud, it'll be better. By the way, everyone, you're going to get CE for this. If you want, you should get it within 72 hours. If you don't find it there, look in your spam. If not, then contact us, but you will get it back to your email you registered with. And we have a lot of questions. Looks like questions are already coming in. Type the questions into the question box, and we have our DS3 team. We have our whole team of MSC representatives that help dentists succeed at dental sleep every day, and they're answering some of the questions as we go along, and we promise to get to all the questions before the night's over. So keep them coming. If we don't get to it immediately, we will get to it. And Rich, you've had a busy day. You're right there in your office. I can see your logo in the back. So we've been doing this for a long time. You're doing it every day, all day long, and that's what we do, is train dentists how to do this. So I think we'll go forward with what do we do. You know, Rich and I, the fateful day we met, a dozen years or so ago, kind of changed our lives to where we decided at one point that we were just frustrated and we were going to help dentists help their patients, because so many people have this problem. I mean, how many patients do you think you saw today, Rich, that could just use your help, and how many of those didn't even know that a dental device was an option? A lot?
Well, they certainly start off that way, Guy, and you know, this is doable. You guys that are getting started out there and you have aspirations of making a bunch of devices, you can do it. We're living proof that, you know, you just get out there and you change the world one patient at a time.
Absolutely, and that's what we do. If you want to know more about what we do, or if you just need help, if you get through all this and it was a little too much information and you have a specific question or a dental sleep challenge, just type in consultation tonight, and one of our dental sleep experts will get with you, answer your questions, tell you how we can help your practices go as far in dental sleep as you like. We're just coming off this meeting last month, second biggest dental sleep meeting in the country. I mean, it was just, I want to shout out to Jason Tierney, who's the brainchild and the mastermind behind this whole thing, and he, you know, really put another great meeting together again that even exceeded the previous years. And when you look at the list of people coming in 2020, we did sell out of rooms this year. We actually were full as far as registration goes. So if you want to come to Clearwater Beach in Florida in next February, just start going ahead and put that down on your calendar and get in the early registration so you don't miss out on the rooms, which are really reasonable, $250 or something like that, as opposed to $400 if you wait until December or next fall to get them. All right, and we got a lot going on here of courses, Rich. I know you're teaching a course for the college there, and I'm doing something out west tomorrow, this week. We have a course in Houston. We teach the best 2-day courses anywhere. You get a dental device, you get a sleep test, and you get to bring one of your team members for under $1,000 for a 2-day hands-on course that you can see the dates here. And for those of you who tune in to this webinar, if you type in before the night's over course, and you can put which one you want, if you know where you want to go, it'll even save you $200 more off the registration. So, I mean, Rich, every time I tell them that, Rich is like,
I'm going to start sending my patients, Guy, that can't afford me to these courses.
Yes, it's a good way to get a dental device and a sleep test. It's worth the more than the price of admission. And we can assure you, if you come to one of the courses, you're going to leave thinking it was the best day and a half you've ever spent. You're going to learn really practical how you do this. And then this is coming up. You get to spend a few days with Keith Thornton again here in a couple times this year. It looks like April, Rich, in October, right?
Yeah, it went well. We did our first one last year. Does it sound a little less echoey, yeah. Guy? Yeah. Okay, well, if I get a little bit closer. You know, we're changing it up a little bit. We're talking about a couple of different things. So if you've done, you know, probably 50 devices or more, that's not a hard number that we draw in concrete, but you know, you don't make this your first course. You know, make the 2-day course that we do your first course, because that's more of an introductory. We hit on some of the higher parts and, you know, how to do combination therapy, and we start, you know, I think doing a little bit more medicine, which I think a lot of us dentists who've been doing sleep a little while, Guy, we enjoy doing that. I think that's part of the attraction of what we do.
Yeah, and I tell you, last year just had rave reviews. They get to spend a few days with you and Keith Thornton. I mean, between you, dozens and dozens of years of experience. So it's well worthwhile. Anybody is interested, you can save $300 if you type in the AHC for the Advanced Honors Course, is what that stands for. And you type that in before the day's over or the evening's over, and we'll get you $300 off it as well. And the next time's one of our most popular webinars, one we do maybe every year or two, because people want to know which device you use and where, and we're going to go through the 5 that we use more than any other ones out there. So let's go on and talk about sleep testing and get to the squiggly lines that we promised. Rich, how many of your patients these days do you think go get PSGs? What percentage? Do you have any feel for that nowadays?
Well, we do keep track of that, Guy, and it's about 15% is all it is these days. So, and what we're finding with that more than anything, Guy, is if I asked you, Guy, what kind of sleep test would you like? Would you like a PSG in-lab test or a home sleep test? Most people would say home sleep test. And then if I said, well, what if your insurance only paid for an in-lab test? Then people might say, well, maybe I want an in-lab test. But we're finding more and more of the payers are only paying for home sleep tests. So again, we want to point them in the right direction. We have some partners that we work with, from sleeptest.com to Blackstone to some of these Snap, these other people. I just want to get people sleep tested, Guy. And I don't particularly care how they do it. I'm not making the diagnosis. We've just got to do a better job. And when I say we, I mean all of us doctors in the United States. We have to do a better job at finding these people and lowering the barriers to get them sleep tested in the first place.
Yeah, absolutely. So I think most people really understand the PSG polysomnograph is in the lab. There's someone in the other room watching you. I've spent many hours in these rooms throughout the years, sitting side by side with these technologists, and what they're measuring, a lot is the same on the home sleep test. But just, if we're going to talk about dissecting these tests, you need to understand what the signals are. And so there's different types of signals that we're going to look at. One is the EEGs, and then we have EMGs below that. So the EEGs are measuring brain waves. That helps us understand what sleep stages someone's in. EMGs, the next one down here on the list, is going to measure muscle activity, and we're going to measure that for bruxism and periodic limb movements. And then we want to measure the airflow, and so the airflow is usually done with pressure. It could also be done, as we mentioned, with a thermistor, which is a temperature sensing device. And then we have these belts on the patient. Those are to determine if the chest is moving or not, and the abdomen. And if that chest and abdomen's moving, then we know the patient's trying to breathe. And when we're looking at those signals, if those signals aren't moving, then there might be a problem with not trying to breathe. Or if they're out of sync, there's a problem. And then, of course, we do pulse oximetry along with pulse itself. And then in the PSG, we also do EKG or ECG. We look at the heart rhythm. So these are the signals that you may or may not see depending on which test you're going to look for. And when we look at these, there may be multiples of each type of these, but these are the types of signals that we're reading. So this isn't, Rich, there's nothing really scary about any of this stuff. We're just putting sensors on people and measuring certain things. And the PSG, of course, has more of those things. This is what I would say a lot of the PSGs, I don't think they do esophageal pressure much anymore. This would be, so anything we clarify on those, Rich, do you think?
No, I think maybe it's only scary for the patient, Guy, who's getting ready to undergo a PSG where they hook all. The hard part, you got to remember, the hard part about testing sleep is we have to put something on you that affects the test itself.
Right.
You can't just lay in bed and we just have a video camera that videotapes you and it gets all of these signals and all of that stuff. You know what the future of this will be, Guy, is probably that little thing you wear on your arm. It measures your heart rate already. It can measure actigraphy. We plug in an airflow sensor and we plug in a pulse oximeter and we can upload it to the cloud. So I know people are working on that stuff already, but no, it's not intimidating. We're just going to try to break it down for you, little pieces at a time, so we can understand it better.
Yeah, and again, this is the polysomnograph. Some of these same signals we're going to measure in a home sleep test as well. And when you look at it here, I think this is where people get really scared. I've got to move my camera to be able to see what I'm looking at here. But as we look down the left here, we go, oh my gosh, this is terrifying. And it really shouldn't be. I want to kind of, I think it's worth our time, Rich, just to kind of quickly go down what are these signals here. These at the top are your EEGs. Those are the signals that the sleep technologist is going to look at the different wavelengths, and you don't have to be an expert in this by any stretch of the imagination, but just understand they're looking at those to help determine if someone is in REM sleep, delta sleep, by looking at the various waves there. The next one down, I can't even read it here on my cover.
I think it's right eye and left eye.
Right, yep. I can't over it. Yep. And so that's for rapid eye movement and determine, again, for sleep staging. So they put little sensors, they're EMGs, they put here beside the eyes, and they can sense the eye movements to help determine what sleep staging. And the next one's the chin EMG. Yeah, that's for bruxism, as sometimes they put it on the masseter, I believe. And so one of the things to note is we do notice a lot of bruxism in apneic patients. And if you talk to, when you sit in the sleep lab with the technologists, they're like, of course, people who have apnea brush their teeth. We see this all the time. It seems like it's news to dentists, but to people in the sleep lab, it's commonplace. And they also look for bruxism of the legs and arms. I think those are the next ones here, right, Rich? The right and the left leg sensors to see if you're twitching your arms and legs. And then here's that thermistor I talked about. That's going to measure your temperature of your air, so we can exhale and inhale. And then we have a flow. And then here's your two belts, the thorax and the abdomen. Some of them have microphones, so you actually record snoring sounds. These are the EKGs or ECGs for the heart. And then we measure our pulse oximetry. And then pleth, which is, geez, I'm having a brain. I know what that is, but do you know what that is off the top of your head, Rich?
I don't recall what it is.
Yeah, I knew that at one point, but I should have looked at this before we put this PowerPoint. Got them all but one here. And body position, and then your CPAP, your CPAP, if they're used at what pressure it was on. So now here's the good news. You're not going to have to look at this stuff, but I wanted to show it to you because this is what they're looking at, and this on the screen is what we call an epic. So, you know, that's for a period of time, and as they're looking at the software, and if you buy your own ambulatory equipment, then you can look at this raw data, and you can make that be 30 seconds or 3 minutes, epic of time that you're looking at here. So the good news is you don't have to be an expert in all that, nor do you have to be on this page, but I think these are in some ways, I'm going to move my camera's picture over here again. This is what we call a histogram. And a histogram is just all that information kind of bunched up together, so we can look at all those signals kind of at the same time. So if you like, this is from a watch pad, I believe, from Itamar. If you look here, we can see the snoring and the body position for the full night kind of laid over each other. Same thing with the pulse and heart rate, and then our sleep stages we can see down here throughout the night, or for whatever epic we're talking about. With the histograms, just a bunch of material that's kind of pushed into one slide, so you can really get at a glance see how someone's doing when you look at this type of information. And again, I don't know, Rich, that for us dental sleep dentists that we have to become experts at even reading this, but it's nice to know what this information is. Do you have anything to add on this particular histogram?
No, but I like looking at this guy because it does give us an overview. You know, we can get an AHI and a supine AHI, but here we can see when this guy's on his back, he definitely is snoring more too, you know. So I think some of us like to look at things differently. You know, we see this visually in a different way. So it's just nice to know what some of those lines mean. Yeah.
And this is his event. So you can definitely see it. What Rich is talking about is right here. There's the supine position, and here's the snoring. And you can see the how that's affected. So that's what we call a histogram. And then, so what about home sleep tests? Well, as Rich mentioned, 15% maybe are doing PSGs these days, and a lot of that's because that's what insurance is only paying for home tests. And when you ask a patient, that's a pretty quick answer most of the time. They'd rather go home and measure this stuff, and they sleep better in their own beds, and you know they might have a more realistic night's sleep, which we'll talk about that in just a few moments, how there's such a per night variance that maybe the home sleeping is more important in some ways than measuring these extra signals. Rich, you know, we preach a lot to everyone we talk to and say, you don't know how good you've got it. To sound like I'm talking to my 12-year-old, but you know, when we started doing this, we didn't have this option, did we? We had to send everyone to the sleep lab 20 years ago. There was no option for ambulatory tests until a little over 10 years ago, and now we can do that. And as Rich said, you know, if you'd asked that same question a dozen years ago, it would have been everybody went in for the PSG, I assume.
Yes, sir.
And to be clear, we as dentists can't diagnose. We can work with our local physicians who can deliver sleep tests. We can buy our own equipment from places like Brabant or Itamar. We can work with sleep testing companies like sleeptest.com that we can order these from. But at the end of the day, a board-certified sleep physician has to read this data. And this might be a typical data that you would receive from a home sleep test. So it's similar. I mean, some of the same things we're seeing here, as I can move my camera over, we can see the flow and the chest and SpO2 readings, the sums, just these two together, all put together. We have audio, snoring, body position. So I think one of the concerns people have often is a home sleep test is not as good, some people think. And other than the EEGs in many cases, we're measuring a lot of, and the EKG, we're measuring a lot of the same information. And when we're just trying to see if someone's breathing at night and their oxygen is dropping, this gives us most of the information that we need. Anything else to add on that, Rich?
You know, if we're just looking at sleep apnea, Guy, it's good enough. I think, you know, there have been a lot of studies done that look at both of these overlaid, you know, where we're using the same types of signals. You know, if you have a patient who has a history of epilepsy or, you know, significant cardiovascular events and things like that, we might want to do that in a sleep lab. But again, that's not our call. I'm not the one making that. I might call the doctor of the patient and say, hey, this guy's got some real issues, man. We should try to get him in the lab to get him tested. I know he doesn't want to do that, but I think he'd be better off. But again, that's not our call.
I agree completely. So we'll move on here. There's some questions coming in I was just looking at. We will get to all of them. And so we're typing in the answers as we go. And one of them was, can you do sleep staging in home sleep test? I just read there. And the answer is, what my favorite answer on the earth is whenever people ask me a question. It depends. It depends on who you listen to. It depends on the equipment. WatchPat has an ability to extrapolate some sleep staging out there. I think if you ask sleep physicians that, they would say you really have to have a PSG to really know how well someone's sleeping, but it's all a matter of an opinion, and this is not a perfect science, as we're going to explain to you in just a few minutes. So what's this here, Rich? I mean, this is central apnea. We don't see that often, but I think one of the things that come up is people say, well, the home sleep test, you can't tell central apnea, and that's just not true.
Well, sure you can. If you have an effort belt, you know, all we're looking at is, are you breathing or not? If I don't have an effort belt, I can't tell if I'm trying to breathe or not, so I can't tell if it's a central event or not. But if I have an effort belt, I certainly can. And we always see a little bit of central sleep apnea events, even in obstructive sleep apnea patients. So you got to remember, you have to have at least 50% or more of the events to be central to even be considered having a diagnosis of central sleep apnea. But again, it's something that we want to look at. That's one of the things that we're trying to teach you tonight.
Yeah, so this is the airflow. We're breathing. We're not breathing. Here are the belts. You know, you can see the belts have activity. They're moving. They're not moving. No airflow, no belts moving. You're not trying to breathe. That's a central apneic event. Now, you could also have an obstruction at the same time, too, by the way. But, you know, it's called a central event because you're not trying to breathe. And, like, I want to emphasize what Rich said. You're going to see this quite often on one or two a night. But to see it 50% or more of the night, which was what you'd have to have central sleep apnea instead of obstructive, you're just not going to see it that often. So it's not near as common as obstructive sleep apnea. So definitions, and this may be remedial for some, but some this may be the first time you've heard this. So we'll make sure you understand what an apnea is. Means you quit breathing for 10 seconds or longer. So that's just measured by the flow. The hypopnea we already showed you, that's that decreasing of breathing, but at the same time your oxygen's dropping. RERA is something that is not measured as often, but it can be very important as far as the sleep quality for a person. It stands for respiratory effort-related arousal, and that's like a hypopnea where you don't desaturate. But if you were measuring sleep stages, like in a PSG, you would go from deep sleep to a lighter stage of sleep. So you're having a respiratory disturbance that's causing you to not sleep well because you're not breathing well, but your oxygen's not dropping. Did I say that right, Rich? I know I'm talking a little bit more than normal, which is, I guess it's not that abnormal, but I know you're echoing. So I'll try to fill in as much as I can. And then snoring is a sound that we hear that is apparently can be deadly. Did you hear about that in the news here? I meant to drop that slide in here and totally forgot to do it. Here in Florida, some woman shot her boyfriend over the weekend for snoring. He tried the breathe right strips, and apparently those weren't enough. So it can be deadly. I can't hear you at all now, Rich. Are you muted?
Sorry, I muted myself. I saw the picture of the lady guy, and she looked like she hadn't slept very well in quite a while. So
yeah, no, it did look good. So y'all can Google that if you didn't hear that. We were going to maybe do an ad campaign, dental sleep medicine, no shots required, but that was Jason's idea. But that may be pushing the edge just a bit. But all right, so I think those terms are pretty familiar to most of you, but some of you, these other ones you may not be as familiar with, and I think that they're important to know. Sleep onset is how long it takes someone to fall asleep, so you have to be measuring sleep staging to know these for sure. And then more importantly, probably is sleep efficiency. So sleep efficiency, is really just how well you slept. For the length of time that you laid down in bed, what percentage of the night you were actually asleep versus laying there and not in sleep. And to adequately measure that, you have to do sleep staging because you have to know when they're awake and when they're asleep. And so why this is important, if you get a PSG in your hand and the patient had a sleep efficiency of 45%, they didn't even get to deep sleep enough to even have the apnea that we're looking for probably. So it can be an important thing to note on some tests as we look at them. Arousal index is basically when you're going from deeper sleep to lighter sleep, and that can be associated with airway events or not. But it's when patients are not sleeping well, they're in deep sleep, delta sleep or REM sleep, and then they jump out of that normal sleep for some reason. SpO2 readings. One thing we look at for this is it's your pulse oximeter. Some people just call it O2. But basically that's your pulse oximetry reading, and it's not a magic number, but it kind of is. When it goes below 90, when your pulse oximeter goes below 90 for any period of time, it can be significant as far as the negative health ramifications, in particular to most of the organs in your body. One doctor described it to me once as once your oxygen goes below 90, your organs start shutting down to conserve energy, and it can cause a lot of strain. And the last one on there is the O2 nadir or LSAT. That's how low the oxygen went at the lowest level. So it's kind of the opposite of pinnacle as your pulse oximetry reading throughout the night. That is the lowest point, and that can certainly show us how bad the apnea is as well. And so the AHI and RDI and ODI, you want to explain those, Rich, or I'm talking too much here?
Yeah. Remember, a lot of physicians will, when I do lunch and learns, Guy, just about every single day here in San Antonio, and I've learned over the years to not say, well, do you even know the difference between AHI and RDI? Because most physicians don't. Instead, I ask, some people use AHI, some people use RDI, REI, ODI. Which do you prefer and why? That's how I usually ask the question. And usually they'll go, well, I like RDI the best. What do you think? Because they don't even know. And this is something that I would recommend that you ask that question, because it can show that you actually know what you're talking about, just to know this right here. If this was the only thing you took away from this tonight, it would be advantageous. So remember, AHI is apneas and hypopneas per hour. RDI, remember it has the R in it, so it includes the RERAs. That's how I remember it. So it's apneas and hypopneas and RERAs, the respiratory effort-related arousals, index per hour. The ODI is just the oxygen desaturation index. So they simply use a percent that they use, 2 or 3 or 4. It seems like most studies I read today, Guy, are using 3%. We do see some that are 1. We see some that are 2. We see some that are 4. They used to all be 4, and most of them are using 3 now. And remember, the other thing I would add into this, Guy, would be the REI. That's what a lot of the home sleep testing companies are using to report the respiratory event index, which is the same as the RDI. So don't get confused with this. I mean, are they used interchangeably? For the most part, they are, but they're not exactly the same.
Yeah, and resistant breath is another one that home sleep tests use that's similar to the RDI, and that's just when they're having trouble breathing. So very good. I'm glad you mentioned that. And we said what the ODI is. So I'm going to just put the numbers up here. A lot of you on the here, it looks like we've got several hundred people on, which is fantastic. So I'm sure some of you know this, some of you don't. We have determined that if someone's going to be diagnosed with apnea, you have to have an AHI of above 5. And 5 to 15, we consider it mild. 15 to 30, we consider it moderate, and above 30, severe. And that's in relation to AHI. And kind of one of the shames here is that I think most physicians and dentists who just know a little bit about this and don't work with this every day think that's all there is to apnea. The AHI is all there is. If we get the AHI below 5, then everything's hunky-dory, great. And that's not necessarily true, because people can have an RDI that's still high and they still feel like garbage and not sleep well. And, you know, when we look at these things, when we talk to the people who help come up with these classifications and talk to a good friend, Dr. Remmers, and other people, how did you come up with these parameters? Why is it 9 seconds, 10 seconds? Why is it 15? Why is it AHI of 5 and not 10? It wasn't one big massive study. It was that they had to draw a line in the sand somewhere. And there's some evidence showing now an AHI of 10 in the absence of comorbidities is really not that bad for you. And a lot of medical insurances won't even pay for dental devices or CPAP. What you have to keep in mind is these numbers for dentists, it's really bothersome to you that there's a number there and you want to think, well, that's just gospel. That's exactly the way it's always going to be. And in fact, it's not. And I pulled this from one of the home sleep testing companies, been doing this for many years, and they do 3-night testing. And 30% of the patients who were normal on one night showed differences on one of the second or third nights. So 72% of them who were normal, AHI less than 5, were above 5. 24% that had AHI below 5 one night was 24, and there was 4%, and actually the number is 4.9 because I remember the study, almost 5% of the people who were normal one night had an AHI of above 30. And this isn't due to faulty equipment. This is due to sleeping differently, to being tired the second and third night because you didn't sleep well the first night because you got the things stuck on you, body position, a lot of other things like that. And the take home on this is we sleep differently every night. And if we were to give someone a sleep test for 50 nights in a row, you're going to get a big variance per night. And when you strap stuff on a human being, it's going to affect how you sleep too. So it's just it's not as exact as most dentists would prefer it to be.
I think, Guy, you hit the nail on the head there. I think that's one of the hardest things that as dentists we deal with. We cross in that line towards medicine, and it's not exact. The crown margin isn't, a wide open margin is acceptable in medicine for the most part, I mean, and it's hard for us as dentists to understand that.
It is, but once you understand it, it's liberating. Because all of a sudden, now you don't have to worry about that crown margin. All we're trying to do is get people breathing better at night. Let's just think about that. That's what we're trying to do. We give someone an apparatus, they breathe better at night, whether it's a CPAP or dental device, and there's degrees of breathing better. So it's not a finite line. You're choking, and now you're breathing well. It's that you're breathing not well, and now you're breathing better. That's what we're looking for here on a nightly basis. All right, we're going to get down to the nitty-gritty for the next half hour about you get this sleep test in your hand. and what does all this stuff mean, and what's important to me, and what should I look at? At the end, towards the end here, we're going to talk about what of this data should you extract out of each one. So when you have a 6-page test report rather in your hand, that you know, here's what I really need to get out of that. We'll show you how to do that. But most of them are arranged. They have roughly these categories. Some of them are a little different. But when you get that in your hand, if you want to take your camera out, take a picture of that, or if you want any of this other information, just type in consult. We can be happy to send you some information or to go through this if it's not good, but if it's not everything you need. But these are the areas that you need to do. And we're going to spend more time on the respiratory parameters than anything else, because that's what has to do with what we're looking for when it comes to airway. I think this is one of your patients here, Rich, that we just pulled this test from, and I don't know that what it says here is all that important, but I think what we're looking for here is this kind of gives you the history and the demographics of the patient, right?
So far.
Yeah, so far. So it's got, the patient, kind of what brought them in, what their health history is sometimes, and, their age and past medical history and so forth. So that's an important part, because we can look at this and kind of get an idea, if we weren't the ones involved in getting them tested, why were they tested, and what other medical issues might we be concerned with when we look at that. The second part here is this part, I think, Rich, was the most intimidating to me when I first started looking at a test. I got to this part and I'm like, oh my gosh, what does this mean here? And you all can read it as we go through it. I think what you just need to understand, what they're telling you here is how they performed the test. What parameters they used. Rich was mentioning 4% or 3%, that they're going to define what they used in this test. In this test, a desaturation was considered 4, and a decrease in breathing of 30% was considered hypopneas. So you can look, and here's the instruments that they use, the leads rather. And I just have another example where it might just say they went by the AASM recommended parameters. So that, it just cites a standardized parameters instead of spelling out exactly how they did this test. Anything on here you'd like to add, Rich?
Good.
Okay, so probably not the most important of this, other than this 4%, because if they're using let's say it's a follow-up sleep study, and they're using 2% desaturation, and your baseline was 4%, you could have some significant different results. And then the next part, sleep architecture, and I don't think we have time to go into detail all the sleep stages and every detail about it, but I think it's worth us taking maybe 5 minutes or 3 or 4 minutes and talking about the various stages of sleep. And I think one of the biggest misnomers is about REM, and I'd like to discuss that briefly here. So when we go to sleep at night, we go through 90-minute cycles where we're falling asleep and we come back through these stages if we sleep properly. And stage 1 is when we first fall asleep, and we have very little of that sleep once we fall asleep the first time if we're sleeping well. Then we move on to stage 2, which is a lighter sleep, and all the good things that we need from sleep, most of them aren't happening in stage 2. So the important parts of sleep are stage 3 and REM cycle. And I think those two get mixed up. Don't a lot of people call REM cycle deep sleep? Do you hear that a lot, Rich? Yep. So I think he's got it mute because of his echo there. I'll just keep talking. The deep okay, deep sleep is stage 3, and this is where you're breathing slowly. You have deep respirations. Your heart rate's down, and that's when we're in our deepest, most nourishing sleep. This is the type of sleep we need to produce all the hormones that we need, which are everything from appetite regulating hormones to testosterone to growth hormone. If we don't have this stage of sleep, we don't feel rested, and we don't produce the things our bodies need to survive. REM sleep is not the deep sleep. REM sleep, your brain's really rapid, just like you're dreaming. Your heart rate's up. That's where we do a lot of our dreaming, and we're being chased by lions. But the key thing for the REM sleep is all of our muscles are paralyzed except for our diaphragm. It's called muscle atonia, and that's where we're most prone to apnea. Our heart rate's up, our blood pressure's up, but all of our airway muscles are paralyzed. So the stage 3 and REM are the most important, but they're also the most likely to have obstructions in it. So how do we see
The only thing I want to add to that, Guy, go back one slide, is remember that the REM cycle tends to lengthen throughout the night. So we alternate back and forth about every hour and a half or so. But remember, a lot of our REM occurs more heavily at the back end of the night. So when we have the ramifications of that are when we do a split night study, for example, and we only look at a baseline for the first half, and then they put CPAP on the patient for the second half, we've severely, in some cases, severely underestimated the severity of the patient's sleep apnea. So that might make a difference when we treat them with a dental device or something. That was the only thing I wanted to point out.
No, that's absolutely true. We're more prone to have heart attacks later in the night because of that. So we have more stage 3 at the beginning and more REM at the end. And about those two stages take up roughly 50% of our night combined. So pushing 25%. I have a slide on that coming up. But this is what it's going to say when you get the sleep study. This is what's going to intimidate you. This is why we're talking about this now. And you can pick up 20 of these and see this a little differently. But when you see this, don't let it intimidate you. I think the things to look for here are the sleep efficiency. See, this one's fairly low. If it says 67, that to me indicates this patient didn't sleep well, probably because they've got 16 leads and someone in the other room staring at them and they're sleeping in someone else's bed. And they got stage 2 sleep we don't care as much about, but they had no delta sleep, which is another word for N3 sleep. So that's N3 and delta, and no REM sleep. So all the nourishing parts of sleep during this study, the ones that we really care about, they didn't get. So that would be, to me, this is either a bad study, which it probably is because sleep efficiency was poor, or this patient's really, really got a sleeping problem. Same thing down here with this one. This one patient slept a lot better. Okay, the REM latency is how long it took them to get into REM sleep, which is not, which that's about right. The patient spent, let's go down here to N3. Oh, this is much better, isn't it? 22% of the night in M3, or that's, again, delta sleep, and 36 in REM, which is really above average even. So this person's sleeping like a champ. They did arousal 7 times an hour that they kind of came out of deep sleep and in, which isn't good. And this WASO is wake after sleep onset. So after they fell asleep, they really only wake 24 minutes throughout the night, which is not ideal, but it's certainly not terrible. So I would say this is an example of someone sleeping really well, and this is an example of someone sleeping very poorly. Rich, do you ever have someone come in and they had a PSG and they go, yeah, but I didn't sleep well?
Guy, every day I hear somebody say, I didn't sleep at all.
Right.
I mean, I didn't sleep a week, and the sleep study will say they slept 6 of the 8 hours, you know. So there's definitely a skewed sense of how much we sleep and we don't sleep, and that's pretty consistent across the board.
Yeah, so if that was this first patient, we'd have to agree with them. If it was this one, we could go, well, no, actually, you slept quite well. And if this person had an AHI of 25, I'd be, my gosh, if you got the deep sleep, you know, you'd really be in trouble. So when they say they didn't sleep well, and if they have poor sleep efficiency, their AHI is probably underestimated in this test. So sleep architecture, you know, we can look at, you know, different percentages of this. But what we're looking for is the latency, the efficiency, the wake after sleep onset, arousal index, and limb moves. So it's just kind of an example. Sometimes they'll show it in a pie chart like this, which is a lot nicer. You can take a glance at that and go, okay, we care about the green and we care about the purple. Well, we didn't quite get enough of that. We want that to take up half this pie typically, or close to it, between the two of them. So this is an example of someone who didn't get the proper amounts of sleep. So they'll display this differently, is what I'm trying to show you when we pick different tests to throw in here, because depending on the test you get in your hand and the lab or the technologist or even the equipment that they use. So we're going to move on to respiratory parameters, which I think we'll spend a few minutes on because it's the most important part, because we're looking for patients who have airway problems. So, you know, when they may put it in a big paragraph like this. And that's, I think, the most intimidating, is it when you're first starting doing this. You're like, what's the AHI? And I'm going to tell you what you want to pull out of this, but as you look through here, there's the AHI. Not bad here. There's the RDI. Then we have the AHI while the patient's in REM. We have the AHI while that person's on their back. So they're doing 2 an hour. There's how low the oxygen went. That's the O2 nadir or LSAT. And then what percent under 90? This one didn't give us to us under 90, right? This one gave it to us under 88. So we'll note that. And then I think this is important sometimes when people have a lot of desaturations. If you see this being low to start with, maybe they have some other pulmonary dysfunction to start with. We start looking at their medical history, especially here in Florida. A lot of people, elderly people, used to smoke, and they have COPD and things like that. So anything else to clarify on here, Rich?
Well, what I would add to that, Guy, is what I do and I teach my staff to do is to either get an underliner or a highlighter and write off on the side, we're looking for AHI, RDI, and if they give us supine of those. That's all I've told my staff. That's all you have to look for. Because, you know, we can get confused if we do this. Remember, Guy, when we started designing the software, we had like 27 things to put in from a sleep test. And what did we learn?
We took a lot of them away.
Yeah, we got rid of a lot of them. So now we're just, you know, I just tell them, highlight it, write it on the side. So on the side, write AHI, RDI, and then supine with a question mark to see if there's a difference. And we write right on that piece of paper. That's how I teach my staff to look at these things and do it.
Yeah, and we're going to show you. So you'll highlight it, write it on that paper, and we're going to talk about, like, we don't take out REM AHI normally. It's not one of the data points that we put in our cheat sheet. I'm going to show you the cheat sheet that Rich and I came up with that we actually put into our DS3 software to make this process really, really efficient. So, and again, you know, this is the same data on a different patient, but here's how this is displayed. So instead of being in a paragraph, they've got it in a nice table format, but my gosh, they gave us a lot of information here too. And you look at this, you're like, well, it's a little easier to read, but kind of scary all at the same time. So again, let's go with what Rich said. There's your AHI. They give it to us in two places, here and here. Okay, I don't see an RDI on here, but I do see that AHI in the supine position Rich was talking about. Right there it is. So this other stuff, you know, it's really just the number they had of obstructive, mixed, or central, or those indexes individually. So you can add all those up, and they'll add up this 11.4. But really what we're looking for are these numbers here primarily, because if you get caught up in all this stuff, and you can't just walk into the test with this, I mean, the patient with 5 pages of this in your hand and plan on having a nice conversation with the patient, because you're gonna get confused pretty quickly. So we'll talk about where we're gonna extract that out. The ODI is the number of desaturations an hour. And the only thing I look at here, Rich, is it should be somewhere in the same ballpark as the AHI. You know, if this ODI is way off, then maybe there's something up, because it's going to be in the same ball. It ought to look, I think it is important how much the patient slept by washout on their back. 26 versus 11 overall. Okay, non-supine 7.3, you can see. So, you know, this patient spent only 21% on their back, but if we could get them off their back, we'll get that down to 7.3 without even a dental device. So that's why that information is highly important. Anything else that you want to talk about on this page?
Nothing but to reiterate what you said, Guy. Don't get confused by all of this stuff. AHI, RDI, supine. You know, just look at that, and then you just pick it out. So they're always going to be a little bit different. You know, and a lot of the questions we have coming in, Guy, are things like, well, why is it 90 or 89 or 88? Now, I can't tell you. You know, I don't know. It's just that physician who interprets those sleep tests, that's what their software is set up to score. That's probably the biggest reason, and people are too lazy to go in there and change those parameters, you know. And it's still a little bit of the wild, wild west out there, you know, but we do like the AHI, RDI, and then we like the LSAT and the time below, whether it's 88 or 90. And again, on our cheat sheet, we have to say what that is.
Yeah, and one last thing I'll mention, like this Cheyne-Stokes breathing, I know what it is. It's not important enough to talk about right now. It doesn't happen that often. You'll see it in congestive heart failure patients. But if you don't know what something is, you've got a big advantage over when I started this. I had to get out the big medical dictionary because I didn't have Google to go look at. Just Google it, look it up, and figure out what it is if you want to know what it is. And you can find out the answers to all these things on the internet. So just if you see something that's confusing, Google it and find out. Here's a WatchPat study from Itamar, I think it is. And, you know, one thing I like about their study here is real easy to read, to me at least. And if you see this little P in front of it, it's because the way they measure is a little differently. That stands for peripheral arterial tone, but don't let that freak you out either. What are we looking for? AHI. Here it is. There's your RDI. There's your ODI. There's your minimum. Okay, that's your LSAT or your naders. So it's the minimum pulse. Underline the wrong thing. The minimum desaturation is 87 over here. And, you know, we do have some parameters below 90 and 88. You know, so if you are looking to buy your own equipment, you might look at the reports. Which ones are easier to read? Which ones have the data in there that are important to you? Okay, so that's the most important part. We're going to talk a couple of minutes, then we're going to talk about how you get this stuff extracted out of here before, hopefully before 9. We're running close to on time. This may be separate sections or it may be the same. And basically they're going to talk about it in a PSG primarily, because these aren't typically measured in home tests, is if they have any cardiac problems with the EKG signals, or if they have leg or arm movements. So they usually put it on the legs, but it's periodic limb movements, we call it. And basically it's bruxism of the legs. Do they have any of that? And if so, how many times an hour? And this one you can see less than 1 an hour. This person was twitching their legs, having basically it's called a movement disorder. They may call this non-ventilatory data too on this one. So these are 3 different tests, same information kind of displayed a little bit differently for it here. I don't take a whole lot out of this unless they obviously have a cardiac problem, but it's probably worth glancing at. I think this one's important for at least one reason. If you send the patient back in and the patient's going back in for a CPAP, they're fitting them for the CPAP, the goal there is to see how well their CPAP works and what pressure. And so what you want to grab out of the CPAP titration study, if you happen to have one of those in your hand, is you want to see what the the ideal pressure was. So if you look down through here, it's a 7, and they got the AHI to 0 with that 7. I've seen it where the pressure is 18 and the AHI is still 18 or 20 or something. So did the CPAP work? If they'll actually wear the CPAP, and if so, what the pressure is. And this is my opinion. I think other people have the same opinion. But the higher the CPAP pressure needed to open up the airway, the more I'm a little bit worried about a dental device doing as well. A lower CPAP pressure, at least I feel we have a higher success rate. So someone with a CPAP pressure of 7, I feel a little bit better about making them a dental device. I don't know about you, Rich. Do you agree with that?
I agree.
Okay. And then the last part of this is impression, and that may be separate, and then diagnosis, or sometimes it's kind of all together. The impression is the diagnosis. And here's, I think, 5 different impressions that I have for you. And you can see everything in here from snoring to obstructive sleep apnea, moderate obstructive sleep apnea, no sleep apnea. You may see mild obstructive sleep apnea with severe oxygen desaturations. Well, you see somewhat like that here. Oh, the wrong button. And I think the key things to look for here is do they have a diagnosis of obstructive sleep apnea? Why is that important? One real important reason, right, Rich?
Yeah, let me show you, Guy. I got it right here in my pocket.
If you want to get paid. I mean, we do treat people who have AHIs of 3, and they have a lot of symptoms, and they have a lot of RERAs, and they can benefit from a dental device all day long. But unless it says on this sleep study, obstructive sleep apnea, if it says upper airway resistance, primary snoring, or anything like that, do not count on getting medical insurance. So yeah, you've got to consider that the patient's going to have to pay out of pocket if you want to treat them. So that's the diagnosis, and then recommendations. If this goes to a sleep physician who's not working with you at the time, you're probably going to see just CPAP on this. And most times they're going to also say that most of their softwares have this prefabricated other thing, lose weight, avoid driving a vehicle. But that's kind of bad too at the times that I've had. I had an 80-something pound woman that it said for her to lose weight, and she was really offended because the doctor didn't take the time to, adjust his template to think that everybody who's obese has this problem. So you'll see these things on here. And the thing I would recommend is if you're going to be working with physicians, if you're going to be working with sleep testing companies. Now, if you work with, some of the companies like Itamar or sleeptest.com or one of the companies that work a lot with dentists, they're already going to have recommendations for dental devices. You know, they're used to working with dentists. But if you're going to start working with a sleep physician in town, or even a primary care who's going to be helping your patients get tested, I would sit down with them and say, we want to make sure that you recommend dental devices for patients along with CPAP for the appropriate patients, for mild to moderate cases, and for anybody who doesn't want to wear CPAP. I think that's a critical conversation you have to have if you're going to be working with local physicians that you're sending patients to, because you don't want them just to get given a CPAP with no alternative treatments, such as a dental device, especially for the appropriate cases. Anything else on that, Rich?
That's good.
Okay, and here you can just see another example, and they'll give you the CPAP. If it is CPAP's recommended and they did a titration study, they'll recommend the pressure, or they'll recommend an auto-adjusting CPAP. I see Richard getting to some of the questions. We'll have time to answer all of them here in just a moment. I think all this is important, but this is the most important part, so I want to make sure we have time to do it. It shouldn't take us too terribly long, but when you get a sleep study in your hand, you or your team, it may be 1, 2, 10 pages long. Rich and I spent hours debating, is that the right word, or arguing? I don't know which what the difference is. But
Depend on how early in the evening it was.
And what we decided is, you sit down, and if you will extract this information we have on the screen out on every one of the sleep tests that you get in your hand, then you can at a glance know really what you need to know to start treating that patient. There's always, as you notice, we have a place down here, well, it's off the screen where it says other. Sometimes there's other information, but what we take on every one of our patients, and I don't do this, my team goes in, they get the sleep test after you, and as the dentist learns how to do it, we make sure it's a baseline test, and so it says what type of test. Is it a home sleep test or PSG baseline? When was the test done? You know, is it 2, 3 years ago? We may have to consider repeating the test. What type of test? Already said. Where was the test completed? What was the diagnosis? If it's not obstructive sleep apnea, we're dead in the water for insurance. Rich already mentioned this, the AHI supine, AHI overall, and the same things with the RDI. If they have RDI given or RDI supine, we put that down. And then the O2 nadir or LSAT, whichever you would like to call that. And then how long we spent either below 90 or below 88, depending on what they give it to us on the test. If you'll extract that information and you can pick up a test and figure out where that stuff is on the test, that's what you need to know on everyone, and that's probably all you need to know on most patients to really at least have a good conversation with your patient. Do you agree with that, Rich?
Not only with the patient, but with the patient's sleep physician, right, or physician. So don't confuse this by all of those lines and all of those numbers and all of that stuff. What Guy and I have politely discussed over the years is what these things should be. And we this has proven itself over and over, Guy, the last few years, that if you just get this stuff out of the sleep test, and you can explain this to the patient as well as the physician that you might be talking to at some point, you are so far ahead of the curve for every other dentist out there, and as well as most physicians.
Right.
So condense it down to this and just get this part down. And I know this is self-serving, Guy, because we make money every time somebody signs up for DS3, but that's part of the reason why we designed this way. And we're seeing things come through. Oh man, I love this part of DS3. You know, it's the best part where we can do this. You know, no other software that we know of can you actually put these in, and then you can actually put multiple tests in or titration studies that you can see that you're looking at here.
Yeah, if you look at what we see here, this would be your baseline, and hit the wrong button. At a glance, we can see the AHI at the different positions went down to a 6, and our oxygen levels went up from a nadir of 82 up to 88. And then real important, we're trying to get that below 90 down to 0, or certainly no more than 1% if possible. And we can see we got it to 0.5 in this position. And so we can make our decisions. And that may be a whole nother webinar on where we stop and how far we go. But you have the data here, especially when you use multi-night follow-up oximetries, like the one we have from Patient Safety, or your other ones that you may use, and we can look at this information and we can make a decision. And then with DS3, it actually takes this data and puts it in a letter automatically for you that you can hit a button and it faxes it digitally through the cloud to your healthcare provider. So before we did this, I can literally tell you I would sit and have 4 sleep tests in my hand trying to make a decision on what to do. Some of those being, most of them being at least 2 to 3 pages long, some of them being 6. Let's even call it 2. I got 8 pages of paper. I'm trying to figure out where I've been, where I'm going. And with this system, it will make this so much easier for you to do. So when we talk to the patient, I think I added these couple of slides to kind of wrap things up with here towards the end. You know, we're going to talk to them about quitting breathing and, you know, how bad this is for you and all the comorbidities and how long your oxygen's down there and your body's suffocating. Don't tell them about the AHI or the RDI or, you know, use big words just because you've learned them. I think, you know, talk to it in terms of what they understand. Hey, you're breathing and you're quitting breathing. And you're quitting breathing for, if your AHI is 15, you're quitting breathing 15 times an hour. Every 4 minutes, you're struggling to breathe. That's why you don't feel good. That's why you're sleepy. That's why you're high blood pressure. So use them all and relate it to your patients as far as what it means to them. When you're talking to the doctors, of course, you can use AHI and all the things that hopefully you've learned through this today. If you want to learn more, that's what we do. We have a whole team of experts. A lot of them are answering your questions. We're going to make sure we got to them all here in a second. If you have a specific question, you just want to know where you could go if your dental sleep practice, type in consult, and one of our trainers will get on and answer your question. So it's worth your time just to type that in for us. We have a 360-degree solution for dentists. We help you screen your patients, learn how to go in through your practice and identify all those at risk, how to have those discussions. Then when you need to have them tested, we have partners that help you get your patients tested with the click of a button, scripts that you can use if you're going to use your primary cares in town, letters of medical necessity, all the things that you need for that. And then when it comes to treating, we help you with device selection. The software helps you walk through each of those steps so that you can do this in very little dentist time per patient. And then we help with medical billing. So you know, everything that you need for dental sleep, that's what we do at DS3. I hope we've given some value here tonight. This is an example of what you get from everything we do. We try to help dentists succeed at dental sleep. That's what our members will attest to if you talk to any of them. We'll give you some value if you tune in again next Tuesday night at April 9th. Not next Tuesday, but the next webinar is Tuesday night, April 9th. And we're going to talk about which devices, which piece of acrylic. We're going to put in some really great milled ones now we're going to talk about. ProSomnus is one of them. The technology, we used to say 4 devices here, didn't we? If you go to our YouTube page, you'll see a lot of them that said 4 devices. And now with some of the new technology, there's more devices that we have at our disposal and have pros and cons. Where are we at with the questions, Rich? I'll give this last bit about Dental Sleep Medicine Insider, and we'll see if we can answer them while you're typing those in. Dental Sleep Medicine Insider is it's a free dental sleep magazine that you get every quarter. You can, if you sign up, you can go back to over 30 issues with everything from how to make a dental device on a edentulous patient, to sleep testing, to networking with physicians, to how you get your Medicare number. So everything that you'd ever want to know dental sleep, we're always trying to address it. So the latest edition is coming out, I think, next week, if I'm not mistaken, or very shortly. So it's free at dentalsleepinsider.com. And there's our courses again. If we don't offer the $200 off any other time. So if you want the $200 off on the course, you got to type that in tonight. It doesn't obligate you to it, but it'll at least secure that discount. And one of our team, Jody, Brandy, Mike, someone will get in touch with you, and you can look. We're doing these all over the country, and we'll be doing even more probably that are on there right now. So you will be happy you came, I promise. It's well worth your time if you want to learn to do dental sleep. So I think there's how you can hold them. Where are we at with the questions, Chris? 4 minutes over.
We've got a whole team of people answering these. I get to answer a few. My apologies, Guy. I didn't make it home today in order to pick up my headset. I got too busy at the office here, but I have a note right here, Guy. I want you to see it's at the office, to stay here. So
I'm going to order you one on Amazon and send it there.
You keep saying that, but you haven't done it yet.
I'm going to do it tomorrow here. Amazon Rich. I'm going to order you 2. Okay.
So, you know, that was great, Guy. You put together a fantastic, you took a subject that's inherently pretty difficult. And I thought you did a fantastic job of breaking it down into some small pieces to help us understand this better. And I really, really think that one of the hangups for most of you dentists out there is that you don't understand the sleep test part of this. And you get intimidated even talking about it. And you know, if you don't, let me put it to you this way. If you have a dental school in your community, go to the dental school for a couple hours one day and look at the sophomore and junior students in the clinic and watch how they interact with the patients. You will see how transparent their incompetence and their lack of confidence is with the patient. And that may be you doing that. I'm laughing, Guy, because I think your son's probably behind you sticking something.
Oh, God.
I think you should get online and say, "Hey guys, how's it going?"
Yeah.
Okay. Yeah.
That's the bear the other day. So
We see you back there. You. But I do believe that, you know, when we understand this better, Guy, you know, people come and visit. We had Dr. Suki here the last couple of days shadowing at my office. And she was like, man, I get this now. I'm so much more confident. I have so much more confidence going back to talk to my patients about this, because we all have different levels of that. But when we get over that hump, the important thing is just to get over that hump. So I think you did a fantastic job of making something that's kind of inherently difficult, and you did a good job of making that simple.
And one of the things we do for our members are, if, you know, we have this whole, we call it the DS3 experience. You go through 4 modules. They're divided up into real concise chunks so that you can, you know, learn the information. But then we have a live teach back with you and your team. So if something like this, for example, your team was like, yeah, I get it, but I have some questions, we're there to answer them for. We have a share screen. We look at the sleep test that you're having questions about, and we'll help you decipher this information even further. That's just one example of what we do at Dental Sleep Solutions and DS3. So, you know, anything from device selection to this, we're here to help you. The courses, one thing I think is really great about it, if anybody, I see a lot of courses coming through. Again, you can get that discount type course, but you'll get a sleep test. And, you know, if you think you might have apnea, we're going to give you the sleep test, and you're going to, on the Friday night, and Saturday, we go through them. And we get to answer questions. If I'm the one teaching it, which I do most of the courses, you know, we sit down and we go through the sleep test and talk about, you know, what these numbers mean. And now you're looking at your own test, which is really, really impactful. And we have found some dentists who have some really, really bad apnea. And I really believe, well, I'm confident that our courses have extended some dentists' lives by just coming to the course and getting the test, because they had no idea, or maybe if they had an idea, they had no idea it was that bad. So
it's the cheapest way I know to get a sleep test and a device. And on top of that, you get to hear Guy talk. If you guys haven't been to a course that Guy has taught, you're really missing something, because he really has a great way of taking, you know, these difficult subjects and kind of breaking them down. And that's, I think, Guy, that's what we have made a living at, is trying to take this and take it to the dentist who doesn't know anything about it, and try to help that dentist become, you know, we want to replace ourselves with 500, 1,000 dentists out there, 2,000 dentists out there who know as much about this as we do, and they can teach other dentists. You know, we really want to move the needle for the country. You know, dental devices only have 3, 4, 5% of the market share.
Right.
We want that to be 50%.
1 in 5 adults.
But 1 in 5 adults has sleep apnea, so there's enough out there. But what I'm talking about is the dental devices only have 5% of the market share. We want that to be 50%. The only way that happens is if all of you dentists out there learn all of this stuff and do it, and you start talking to the physicians and you start talking to your patients and you screen them and you get them sleep tested, and we start doing this. We're starting to really see some momentum here. We really are. When Guy, just look at me, Guy. I was the first guy through the wall and I got bloody. That's how I lost all this hair and all that stuff. Staying up debating all of these things, with how we do that. So you all are our greatest success out there. Those of you who take your time out of the week and you listen to us talk and you do this, and we appreciate that very much.
Yeah, Rich, and I'll end with this, because everybody, you get your CE, don't feel you're obligated to hear us go on, but I think this is a good story. Each week we have a customer service meeting, and the goal there is just to bring the team together. Brandy and Lisa have done a great job of organizing this. Each week we talk about our successes and what we can do to better help our members. And today we talked about a few things, and Rebecca, one of our team members, brought up that, we've had such positive reinforcement from our members that, that through our efforts, she said, I just never thought I would work at a place where I come, and because we're here today, there's going to be all these people throughout the country who are going to help their patients live better and live longer. And it's just a worthy cause. And that's why we started the business in all sincerity. And everything we do is focused around that. And I think we've moved the needle some, Rich. Because we have such a great team of everyone that's working as part of the Dental Sleep Solutions team. We've got a lot more to do, so get out there, try to start doing these devices. Don't be afraid to get started. We're happy to answer some questions along the way. That's what we live for. We hope to see you again in a month. We talk about dental devices. If anybody needs anything else, you know how to get. Let me flip it over to our contact information here. There's how you get a hold of us. I looked through here. I think we've gotten most of all the questions, didn't we, Rich? Is there anything we didn't get to that you know of?
I'm taking one more look here, Guy.
Man, there's a lot of questions today. That's great, though. Let's see. I see check marks in most of them. So, wow, our team is so good, Rich. They've gotten to, I don't know if there's anything. Yeah, we even got a great job team from Dr. Boses. Thank you. I don't see any other unchecked things there. There's one.
Let me go up, Guy, about in the middle. So AHI of 5 to 15, 15 to 30. That's the same for RDI. Dr. Mascaro asked that. So there's not a different scale, thank goodness, to confuse us even more. Like AHI of 5 to 15 is mild, but an RDI of 5 to 18 or something like that. No, there's not a different scale. That's all the same.
There's a question here about REM AHI. Do you find it more difficult to treat patients who have higher REM AHI, REM-dependent AHI? That's a good question.
Say that one more time. I was reading the question.
Is it more difficult to treat patients with higher episodes in REM than not? Or out of REM. So high REM-dependent, like the supine-dependent AHI, that's a good sign, because we can get people on their side. I think dental devices work better. The question is, for people who have higher REM AHI, so more REM-dependent AHI, do dental devices work as well? I can tell you that they work. If you look at some of the cases we've done, I would say maybe it's a little bit of a caution. I would probably lower the expectations a bit. That's my opinion. I'm interested to hear what you would say. Do you understand the question, Rich?
I do. Thank you for clarifying that. I'm not sure what the literature about that says. I will tell you my personal experience is that those patients are more difficult to treat. It always helps. Our dental devices almost always help. When we look at the apnea load, this is how many apneas they have, and you multiply that times the hours they sleep and et cetera, they're having 1,000 a night or whatever it is. And if we can get that down, we're helping that patient. We're reducing that mean disease alleviation that we talk about, Guy. But I will tell you that it is more difficult. So with a very high AHI in general and a very high REM-related AHI, big neck, big guy, very symptomatic, a dental device would not be my first choice for that patient. If that was my brother sitting there, I would say, look, brother, you got to at least try CPAP first. You know, let's see how you do. And remember, you know, Guy, I think it's a good thing to say to most of the dentists out there, it's not always an either or thing. I truly believe that the best way to treat really severe sleep apnea is with a dental device and CPAP.
Right.
It absolutely, unequivocally is the best way to treat. So it's unfortunate that insurance companies have made it an either or. Right. Medicare has said same and similar, we're not going to pay for two. Well, you know what? 10, 15% of the population, in my opinion, needs both. Right. To treat their sleep apnea. So you have to have that conversation with the patient. You have to be confident enough to say, you know, look, a dental device is going to get you partway there for sure. We don't know if it's going to get you all the way. So never say never to CPAP, you know, even if we have to combine therapies or we have to do something like that. So I think anybody who has severe sleep apnea, you should at least say that on the front end.
I think the question there is, on that same patient, what if they can't wear CPAP? So you said it wouldn't be my first choice. Totally agree with everything you said, but it sure
would be a close second choice.
It would be my second choice. So if they can't wear a CPAP, won't wear a CPAP, they tried the CPAP, and they're just can't deal with the claustrophobia, then all day long we'll make them a dental device, and we have some incredible success stories. It's just not our first choice. I mean, it doesn't mean it's our second choice for sure. And if that doesn't do it, then there's other things we can consider, MMA, surgery, and so forth. Bite changes, I will say tune in next time, because we're going to talk about using the AM aligner, getting the bite recaptured. To me, that's your answer. That's the most, it doesn't address every bite change, but if we've been doing this for 20 years each almost, long time, and we didn't use repositioners. I didn't even know it could change the bite when I first started doing this. Now every patient comes in, they're educated on recapturing their bite daily, and if they do that, which we'll show you how next time, they will not have a significant bite change because they're going to notice it. Just the mere fact that they're observing their bite every day. So that's the answer to that question, at least briefly, and we'll show you how we make those AM aligners if you're not already familiar with it, which you may be.
Dr. Rosenbaum has left, but he did bring up a good point, Guy, that we kind of missed in this, and that is the night-to-night variability. Guy put this together, and he asked me to look at it, and I'm sorry, Guy, I didn't catch that either. But yeah, we're seeing some of the companies, Snap, for example, one will do 3 nights of a home sleep test. I saw 3 of these today, Guy. 3 consecutive nights, AHI 6, AHI 10, AHI 14.
Well, yeah, we did address that. But you were answering the questions, but.
Well, then I take back what I just said. I'm glad you addressed it. I must have not been paying attention when you did that. But remember that there is night-to-night variability in there, and that's what makes what we do so hard.
There you go.
It's just, thank you.
So it is. It's very.
I'm sorry, I wasn't paying attention. You
it's all right. It's all right. But there is, and that's what makes it difficult, as Rich said. How applicable is all this for children? That's a whole nother subject and a very important subject.
It is, I think, very applicable.
Yeah, it's the reading of the test is all the same. How we test them. I think the take-home message would be my standard recommendation. If you have a child that you feel may have airway problems, I would try my best in your area to find a board-certified pediatric sleep specialist to work with. They'll get this stuff. You try to work with other people, they don't understand it. If you live in a rural area, it could be challenging, but the tests are the same. They're going to measure some of the same stuff, but the AHI and all that's different. If you have an AHI 3 on a child, on an 8-year-old, that's bad news. Yeah, of anything one per night is bad. A
child only has to have one single apnea event to be diagnosed with sleep apnea. And what we're learning is that they're missing out on a lot of cognitive development, that they may never get back. So you think from ADD, ADHD to bedwetting to, a lot of this kind of stuff. So this is a big deal with kids. And somehow, we've got to raise the bar there in the awareness, Guy, as we do this more. That may be an idea for us to do a webinar on kids. You know, if Jason's still listening, that would probably be a very good one to do. We can bring in some people that know more about that than you and I, Guy, that to help us out on that.
Yes, it's not our expertise, but we know the people who are. So that would be fantastic. I think that's a great idea. I just wrote that down. All right. I think we've got them all.
You know, the other thing, you know, what if they cannot wear CPAP? You know, again, I think maybe that was answered when you said, you know, yeah, we're always going to make them a dental device if CPAP doesn't work, because any help is better than nothing at all.
Absolutely. So, all right. Well, I think
I don't know that we've ever had that many questions and comments, Guy, on what we've done in a webinar. We've done these for a long time, so that's a lot of good engagement.
It was. We've been doing these for what, 8 years or so, probably the total. So there was a few hundred people on. It was great. We appreciate you all's attention and taking your night to be with us. And again, don't forget our next one's coming up. You'll get an email for it, and I think everybody's got our contact if you need. So like I said, we'll get going here, Rich. I think it's 9:20. It's late for us, so at least here in Eastern time. I look forward to talking to you about dental device selection and maybe seeing it, one of our courses coming up. Look forward to meeting everyone that comes. We have a good time too, and in addition to learning a lot. So I think that's it, Rich. Anything else? I'm writing it in. I'm getting an email in a minute. I'm getting on Amazon as soon as I hang up. You watch. They'll be in your office in 2 days. All right. Sounds good.
Apologies.
Everyone have a good night. Hang on, buddy.